All right, looks like our presenter's ready. I would like to introduce Dr. Tacke, who will be giving our grand rounds today. After graduating with honors from Whitman College, majoring in psychology, Dr. Tacke attended the University of Washington School of Medicine, class of 2019, and then moved on to his psychiatry residency at the University of Washington Department of Psychiatry, Idaho track, where he's now in his fourth year and holds a position of chief resident. He has been accepted for fellowship at the Oregon Health Science University in the field of consult liaison psychiatry, which he will start this July. Throughout his education, Dr. Tacke has participated in research and shown a dedication to improving the medical field. He has assisted in quality improvement projects at the University of Washington and here at the Boise VA. He has shown a dedication to furthering education in the field of psychiatry throughout his time. Go ahead and take it away, Dr. Tacke.
Yeah, thanks. I appreciate everyone being here and thanks for having me. Are you seeing just the normal presentation or is it the presenter view?
I think it's the normal presentation, but you haven't put it into presentation mode.
Oh, okay.
So we see the slides on the side.
Okay, let me just reshare really quick. Okay, how's that?
Perfect.
Okay, cool. Well, the title of my talk is Neuropsychiatric Effects of COVID-19. So I appreciate the opportunity to kind of nerd out on this with you all for our time together. I don't have any disclosures. So I wanted to start off by kind of just giving some background on how I got interested in this topic. And so it really starts at the very beginning of the pandemic, which in my mind is like February 29th, 2020. And the reason that I remember that is because I was an intern doing my internal medicine rotation in Seattle. And it was our last call shift of the rotation. And COVID was something that we heard about, but wasn't really on the forefront of our minds until they made the announcement that the first US death from COVID happened in the Seattle area and that there was an outbreak at the Life Care Center in Kirkland. And so kind of from that, there was a lot of concern that there was likely community spread in Seattle, and the whole atmosphere of the hospital just abruptly changed. And so just in the middle of our call shift, all of a sudden we're like kind of on the forefront of this pandemic and started seeing admissions with people with respiratory illness. The next patient that I admitted was a transplant patient with respiratory symptoms that was flu negative. So my attending was like on the phone with the CDC to figure out how to get this person tested. So it was just like a whole whirlwind that kind of happened suddenly. So then a few days later, my rotation ended and I kind of left with mixed feelings just because on the one hand, it was like a relief almost to not be in such the like front lines, but also kind of an identity crisis and wondering like, you know, I'm a physician, there's this crisis happening. Like, what is my role as a psychiatrist going to be? Like, how does that all fit in? And then the next rotation I ended up going on was neurology. And the neurology residents that I was working with had a kind of similar approach and questions on like, yeah, what is our role in this? Really empathizing with our colleagues in internal medicine who are in the ICU and helping people more directly. And I remember one of the neurology residents saying like, wow, could you imagine if this ended up having like neurologic issues or psychiatric issues coming from this pandemic? So I ended up kind of foreshadowing what I'm going to talk about in the presentation. So then after my month on neurology, I went on to psychiatry and was working overnight at Harborview, seeing medicine consults and seeing patients in the ED, and started seeing people coming in with new psychosis who were COVID positive, manic patients who were COVID positive, and my brain was wondering about the connection and just seeing like, is this a coincidence or is there anything else kind of going on here? So that's kind of how my curiosity in this topic developed. And so in this presentation, I'll talk about the pathophysiology of COVID, just a kind of brief review and like how we know it impacts the brain, and then go through the impact of acute COVID infection and then chronic COVID infection or long COVID, and kind of the current status on what the research is in these areas, and kind of what our role is as mental health providers at this stage of the pandemic. So just briefly, I hadn't looked at these numbers in a really long time, but to show how far it's come just in the past 3 years since those very first deaths, it's like mind-blowing to really see it, how many patients have been impacted by COVID and how many deaths have occurred in the world, and just in the US, which is likely an underestimate, but almost 100 million, over 100 million infections and 1 million deaths as of last month. So first part of the presentation is just doing a little review and some immunology and microbiology on COVID and what makes it unique and why it impacts the brain. So as a virus in the coronavirus family, the SARS-CoV-2 virus has a lot of unique properties that make it unusual. So one of the things is the cleavage site on this spike protein that we've all heard a lot about, allows it to really efficiently enter human cells, more so than other coronaviruses, and which that all contributes to making it very highly transmissible and infectious. It also causes a lot of tricks within our immune system that allow it to damage our cells both through inflammation and by infecting cells, and then also making it really hard for our bodies to fight. And so it can linger on a long time, which is, I think, why we're seeing this new phenomenon of long COVID. So one thing that it does is it causes a delayed immune response, but then all of a sudden will push a lot of inflammation, which is that cytokine storm that we've all likely heard about. And when you have that amount of kind of excess inflammation happening, it actually ends up downplaying our adaptive immune system, which normally would help target specific pathogens and fight them like in a more targeted way instead of just the excess inflammation. So this picture kind of shows how it's impacting the immune system, basically by causing a lot of inflammation at once and then suppressing our B cells and T cells, so they're less able to make antibodies to target the virus specifically. It does a couple of other things that make it hard to treat and can have it result in just a wide impact in the body. So it kind of disguises itself by putting different sugars on its membrane that cause our body to make some antibodies that don't actually neutralize the virus. And then it also is efficient at hijacking the host cell machinery to replicate rapidly and cause the cells to arrest in their cell cycle and not work doing their normal things, which is important for us in that it explains how it can potentially lead to issues within the central nervous system and just the cells in our body not working efficiently. So how does this all impact the brain? So it was suspected pretty early on that there would likely be some neuropsychiatric effects of COVID because from studies on previous coronaviruses, like SARS and MERS, they knew that there was neuroinvasive potential. And there were a couple of different theories on how this was happening. So one of them was that the virus enters through the nasal cavity, which is where our olfactory nerves are to help us smell. And the virus would essentially kind of crawl up those nerves and then enter the brain through the olfactory bulbs. And then that's how it would enter the central nervous system. Another theory is that it enters just through, spread through the bloodstream. and going in through the blood-brain barrier and then entering cells through the ACE2 receptor, which most commonly we know those exist in the respiratory system, but they have found that those receptors are present in certain areas of the brain. And so in this theory, the virus enters the brain the same way that it enters the lungs and other parts of our body. It attaches to the receptors and then is able to invade that way. So I think this is still not completely known, but these are the two main theories right now on how this is happening. So then how does it go on to cause damage? So again, there are two theories right now. Initially, the thought was more that the virus itself was causing direct damage to neurons and cells within the brain. And then more recently, the idea has been that it's causing damage mostly as a side effect of all the inflammation that the virus causes in the body. There's evidence on both sides, so it's probably a combination of both of those things. But those are the two kind of overall theories. And then there's also other ways that it's damaging the brain. So it causes a lot of issues with your vasculature leakage and increases likelihood of blood clots. So all these things can lead to strokes, infarcts, hemorrhage within the brain. There's some studies that have shown that the virus will affect the astrocytes, which provide support for the neurons in the brain. And when those cells are affected, they can't regulate the environment in the brain very well, and the neurons aren't supported and they can end up dying. And that's what that picture is showing on the right. There's also just the general inflammatory damage from the cytokine storm. And then apart from all that, you also have all the other things that the virus is doing in the body, affecting pretty much every single body system. So if people are not getting enough oxygen because of pneumonia or infections in the lungs, then that's going to cause issues. If they're having organ failure, all those things are going to impact the brain because it's a very vulnerable organ and it takes a lot of energy and good homeostasis in the body to function well. So how does this end up impacting the structure of the brain? And this is a kind of big deal study that came out last year that was published in Nature that was looking at the impact of COVID infection on brain structure. And so the participants were part of a different study where they basically got 2 MRIs, but then the pandemic happened. And so they were able to identify patients who had COVID between their 2 MRI scans. And these were all adult patients in the UK. So they had 400 patients who had developed COVID between the 2 scans and 384 who did not develop COVID. And what they found was that in the patients with COVID, there was a reduction in gray matter thickness and tissue contrast in the orbitofrontal cortex and the parahippocampal gyrus. They also found that there was some tissue damage in the area of the brain that deals with smell and our perception of smell. But I think the biggest finding that's shocking is that they actually found a reduction in the overall brain size of patients with COVID. And they, as a part of the study, did a bunch of cognitive testing and found that there was cognitive decline in the COVID participants between the 2 time points. And these studies, they were able to compare people's own individual scans with each other and the groups of COVID patients and non-COVID patients as well. So there was a lot of ability to control and kind of focus the imaging and seeing the impact that COVID could potentially have. When they excluded 15 patients who had severe infections to be hospitalized, they still found these effects, which is shocking in that most of the patients then had an infection that was mild enough where they didn't need hospitalization. So this wasn't just the patients that were kind of most severe in the ICU. This is just patients who generally just got COVID. So this was, a kind of big deal study that really showed the structural impact that infection can have. And then apart from kind of the neurobiology and structural findings, these are more clinical findings that have emerged following COVID infection. And so the rest of the presentation, I'm gonna more focus on these, kind of both the results of acute infection and then chronic. Anybody have any questions so far? All right. So, this next part, I'm just going to talk about the symptoms in acute infection. So delirium is the most common presentation, neuropsychiatric manifestation of COVID, and it's more common than in other respiratory illnesses they found. Up to 2/3 of patients with COVID on ICU admission have delirium, and sometimes it's the only presenting feature of infection. And it can affect those who are younger and typically don't have other risk factors for delirium. The big question is delirium from COVID different in any way than kind of normal delirium that we see in 1 to 2/3 of patients in the hospital? And so this group at Harvard looked at patients with COVID and delirium and the non-COVID and delirium on their psychiatry consultation service, and started to categorize the different symptoms in each of those groups and try to figure out if there was a difference in presentation. And they found that the patients with COVID usually were less medically ill. They didn't have a lot of the same chronic conditions as patients without COVID who had delirium had. So it seems that it could cause delirium in younger, more healthy patients. And then in terms of like clinical symptoms, they had a lot more of a hypoactive presentation. So more myoclonus and hypertonia, and then a lot of withdrawal, and then kind of akinesia, agoia, and alogia, which are all basically deficits in motivation for movement and speech. So they tended to be much more on the hypoactive side. They also found that there was an association with COVID and akinetic mutism, which is a syndrome when patients are awake, but they don't speak and they're mute, and they don't have a lot of motor motivation. And it's similar to what would be like thought of as kind of a motor catatonia. So almost catatonia, but without some of the affective and behavioral components. And the thought behind this was that the inflammation that's caused by the COVID infection was depleting dopamine in the mesocortical limbic pathways that are needed for motivation and movement. So from this, the Consult Liaison Psychiatry Academy has put out recommendations for managing COVID delirium. And there's certain strategies that are kind of important to take into account when managing these patients. And one of them is just making sure that there's a way for virtual interactions, because a lot of these patients end up isolated and in rooms by themselves, and there's just less contact with providers and their families. And so paying special attention to that and being able to have a way to virtually reorient people and schedule virtual interactions. And then on the pharmacologic side, leaning more into the alpha-2 agonist for behavioral management. So that'd be dexmedetomidine, Precedex, and clonidine are more of first-line treatments for this, as opposed to antipsychotics. And the thought behind that is because there's likely already a lower dopamine state that antipsychotics could exacerbate that and lead to more risk of side effects. So if you are using antipsychotics, prefer to do more of the low potency end of things as opposed to higher potency. But these are all still just kind of general recommendations, and there's nothing that really is like a, slam dunk or too different from how we might normally treat delirium, but just a few things to pay attention to. Because of the association with akinetic mutism and some of those motor findings, there's been a lot of curiosity on the impact of COVID and catatonia, which was something that was recognized early in the pandemic. Right now, the research isn't strong enough to really identify any causality. The literature is mostly just focusing on more description and seeing if there's an association. The biggest study that came out last year was looking at co-occurring catatonia and COVID-19 in hospitalized patients in 2020. And they were able to get data from a national database that covers something like 90% of the hospitals in the US and look at discharge diagnoses. So they had 32 million patients that they were looking at and found that around 16,000 had a diagnosis of catatonia, and then 610 had catatonia and COVID infection. So I think from that we can say that it happens, like people have catatonia and COVID. We don't really know the causality, but we do know that those patients tend to have an increased length of stay and higher co-occurrence of delirium. The other major review that's out right now is more based on a bunch of different case reports. And from that, still hard to draw any real conclusions, but found that there was a pattern where catatonia would arise more in the acute phase of COVID infection. A significant number, so 44%, did have prior psychiatric diagnoses. And they tended to all respond just to the typical standard treatments for catatonia, so lorazepam and then ECT if the lorazepam wasn't effective. But there isn't really anything from this to argue for causality, and not a lot of information on if the catatonia would resolve spontaneously once COVID resolved, or too hard to say, I think, that it is like a definitive medical cause of catatonia. But I think if there was a patient with COVID and catatonia, there's enough support in the literature to say that yes, this happens and it could be contributing. But we still need to know a lot more. What we do have more information on that I think is really interesting is acute COVID and psychosis. And this was something that I did see as an intern, where people had new onset psychosis without a psychiatric history in the context of getting COVID. So this review was looking at 57 different case reports of new onset psychosis or exacerbation of stable psychosis during COVID infection. And they did a good job of eliminating delirium, catatonia, psychotic symptoms from steroid use, all the other things that could kind of cloud the picture of what was going on. And they did find that in terms of just their demographics, that the age of psychosis was usually in the early 40s for both men and women, so a little bit later than you would see for a primary psychotic disorder. 43% just had mild COVID symptoms, so it wasn't necessarily the most severe cases. And then what I think is really interesting is about 2/3 had no prior psychiatric history at all. And then 35% had even no family psychiatric history. And out of the patients that did have a psychiatric history, substance use was the most common, and a prior psychotic disorder was only in 2 of the cases. So a population that didn't have a lot of prior psychotic episodes or indication that they were vulnerable to psychosis. They found that the most common psychotic symptoms were delusions. So 93% had delusions, and then that was followed by auditory hallucinations and then visual hallucinations. They were treated by a bunch of different antipsychotics. There wasn't really one that was favored more so than the other when they looked at the cases, but most patients responded. And then what's interesting is that the symptoms lasted for 2 to 90 days, but then in most people just completely resolved after the infection was resolved. In about 8%, the psychosis resolved, but they had other lingering psychiatric symptoms. And then the rest of the patients, they just didn't have enough information to know about their prognosis. So interesting that, this is something that I think is pretty compelling as a potential acute medical cause of psychosis. And that's led people to wonder, could COVID be a potential risk factor for development of psychosis? So this was a different study that was looking at different neurologic and psychiatric diseases and the development of those following COVID infection. And they followed patients for 2 years. And it was a patient population of 1.2 million people. And so they matched these with the same number of patients who did not have COVID but had another respiratory illness over the same time period. And they found that there was an initial risk of mood disorders in COVID patients, but then that returned to baseline 1 to 2 months after acute infection. But then there was an increased risk of cognitive deficits, dementia, and psychotic disorders. And that was a risk that remained elevated even when they were looking at 2 years from their initial infection. So that they show that in this graph here, how the red line is patients who had COVID, the blue line is just any other respiratory illness. And even 2 years later, there's still an increased probability of psychotic disorder developing in the COVID patients. So we don't really know exactly how this might work and if this is a potential risk factor or if it'll be something as we get more data will not be as significant, but I think from what we know now, it seems like there could be a potential risk factor there in uncovering something or causing something. So something that's interesting, and I'll be intrigued to know what happens next. Other things that they've looked at, I'll just go through these briefly, is there's cases of COVID-19 associated NMDA receptor encephalitis. And then another thing that people looked at is development of mania, which I think there's less compelling evidence for than the psychosis literature. And the main issue is there isn't enough information and hard to rule out mania induced by steroid use, since that has been such a big treatment in COVID patients, especially hospitalized ones. So there's been incidents of it happening, but I think harder to determine any causality or know exactly what's going on with that. That is the end of kind of the acute COVID infection. Any questions coming up for people or comments? All right. So the next part, I'll talk about chronic infection and long COVID, which is something now that we've likely all been hearing about. Long COVID is a term more colloquially used, but it at this point does have different definitions based on what you're looking at. So the NIH, CDC, and WHO all have different definitions, but in general, it's kind of lingering COVID symptoms about 3 months post-infection. The more academic term, if you're looking for literature on this, or I think this is also a newer ICD-10 code, is neuropsychiatric post-acute sequelae of COVID-19, or NeuroPASC. And this is becoming a real issue and something prevalent. And so about 16 million US adults have symptoms of COVID that have lasted more than 3 months following infection. And about 4 million have symptoms that significantly reduce their ability to carry out day-to-day activities. So it is becoming something that is a source of disability and all these issues with people's productivity and ability to live out their daily lives. And common. And so about 76% of patients in this one study had ongoing neuropsychiatric symptoms from COVID, even 6 months after infection. And so I think the reason that this is something we need to know about as psychiatrists is the neuropsychiatric symptoms are what has become kind of the major symptoms of long COVID. And those are the reasons that people are seeking more care and coming into the hospital for, or coming into clinics and asking about follow-up because they're so debilitating and really common. And I have seen a few patients come in curious about COVID and having symptoms of cognitive issues and attention and wondering if it was the cause. And before really researching this or looking into it more, I was always felt like I was more skeptical. And I think that was because in general, this is all so new and complicated and we don't really quite understand how it all works. But I think the more that I've read about it and the more that we're learning about it, it is, a real thing. And people deserve lots of validation for feeling these symptoms and experiencing them. I like this graphic this is borrowed from one of the presentations at that CL Psychiatry conference I went to. And it explains just how complicated it is and how there are all these different pathways that lead to the long COVID syndrome. So in the blue is most of what I've been talking about, which is the more direct impact that COVID has kind of on neurobiology and within the body that potentially could increase the risk of developing a psychiatric disorder. So there is likely a direct impact of the virus itself and the infection. Then you have a huge yellow box here of all the other things going on in the pandemic that are contributing as well, that I haven't focused on as much, but are equally important. And a lot of this we've all experienced. So just living in the context of a global pandemic, impact of loss of employment, reduced social interaction, changes in dietary habits, changes in physical activity, just the stress of it, all can contribute in either developing a new issue or exacerbating something that was already there. So you have that whole, all those factors contributing. And then you also have this kind of green box, which is that there was probably something going on before the pandemic happened, before their infection, that was undiagnosed, but it was really through the increase in healthcare utilization and seeking help under the idea that it could be long COVID that diagnosed something else that was probably pre-existing. And so all those different factors come into play when looking at long COVID and make it complicated to treat, but also allows for a lot of different pathways to intervene, because it's not as if it's only the virus causing this or only one thing. There's a lot of different factors where you could potentially have interventions. This was a review that was looking at what are the most common neuropsychiatric symptoms of long COVID. So they were looking at 18,000 patients through a variety of different studies across the world, and found that the most common symptoms were insomnia, fatigue, cognitive impairment, anxiety, and PTSD. I'm going to spend the most time talking about cognitive deficits because that's what we have the most information on right now, and often the thing that causes the most distress and kind of debilitation in these patients. So the cognitive deficits that they found based on this review kind of span a variety of different things, but the most common ones are what they categorized as cognitive dysfunction, brain fog, and fatigue. And so these are things that are occurring 3 to 6 months after infection, but then sometimes still happening at a pretty high frequency, even 6 months out. They've studied more specifically what the cognitive deficits are and done different neuropsychiatric testing to try to identify, like, is there some sort of pattern within the cognitive domains on like what long COVID is. And right now they've kind of basically just found that there are deficits in a lot of different areas and not really an identifiable pattern yet. So multiple studies have found deficits in general executive functioning. There's also deficits in verbal fluency, memory, mental flexibility. They've looked at attention, MoCA scores, and all these things have been shown to have decreases following COVID infection. So right now, it doesn't seem like we know exactly what sort of deficits it causes, but in general, there's a lot of support that there is something going on with that, and it's impacting a lot of different areas. One major area that we are all learning more about is this idea of brain fog, which again is a more colloquial term that can be hard to define until you've experienced it, and then it becomes more clear. But basically it is kind of the feeling of just like cognitive slowing, and that everything is just taking a lot of effort. And I think the best way to understand it is through more qualitative studies. And so this was a quote that I liked from one of them, which is from a previously like very high functioning person who got COVID and then has been suffering from brain fog. And she says, one of the things I've realized is how many things I do in my normal day, I'm not talking about work, just in a normal day, that are cognitive, that I didn't previously think of as being cognitive. So a supermarket, the amount of sensory information and just staring at a row of things, looking for the food that you want, remembering where things are in the aisles and planning your trip so you don't have to walk backwards and forwards around the shop. That surprised me. Not just can I walk around the supermarket, it's planning, it's getting there, it's choosing stuff. All of that is actually really difficult. So yeah, I like this because I think it highlights just everyday tasks can just seem monumental and overwhelming and challenging, and you don't really realize how much we do in our day-to-day lives that takes a lot of pre-planning and attention span issues and all those things that can come to light once your normal cognitive capacity is not there. So because of this, and like I was saying before, a lot of patients are now looking to primary care, neurology, and psychiatry for help with these sorts of things because it is in our field, in our realm. And so we're starting to see more patients coming in with symptoms of long COVID. I think part of that too is that it's something that's in the media a lot and actually has a name and a label, which can prompt people to come in for help. And there are now like long COVID clinics where psychiatry is a big part of that. And as part of my fellowship, I'm going to be working in a long COVID clinic. And so this is something that is going to become, I think, more of a role that psychiatrists and mental health providers are going to be playing. And so what do we even want to look for when we're seeing these patients? In terms of history, you want to have a good description of what the current symptoms are that are bothering them the most, but also what their initial COVID symptoms were, and when they had their infection and kind of the time span and how long it's been. You want to have a history on how severe their infection was. So were they hospitalized? Were they on a ventilator? How long were they in the hospital? All those sorts of things, trying to gauge the severity of their infection. It's important to look at what sort of treatments they received, since some of the treatments can have neuropsychiatric impacts, or kind of helps you gauge, again, how severe the infection was. So whether they got steroids, antivirals, or received antibodies. You want to know their vaccination status, since being unvaccinated would make it more likely they had severe infection, or if they had an infection and are still unvaccinated and have long COVID symptoms. There was initial research that was showing that getting vaccinated is something that can actually help treat the long COVID symptoms, because it's essentially giving your body an extra boost to fight off the lingering infection that's still there. That was more like a year or so ago. I don't know if they've studied that more since then, but I think in general, being vaccinated is going to be protective and better. Reinfections you'd want to know about, since it just is increasing the chance of having lingering virus or having your brain take more kind of insults from infection. Want to know a thorough review of systems, since COVID impacts all sorts of different areas of the body, and maybe they're not thinking as well because they're having more lingering symptoms in their lungs and not getting adequate oxygen or something else. So you want to be paying attention to really every body system, even though you're primarily assessing their cognitive issues. And then getting a good past medical history to understand their comorbidities. It is a time to do a physical exam, or at least have a thorough one done by their primary care doctor, and then leaning into consulting other specialties and diagnostic tests, just to like make sure you're being thorough and ruling out other things that can be contributing. Since kind of at this point, it's more of a diagnosis of exclusion, but I think the evidence is building that COVID is having a direct impact as well. So, but I think just exploring other causes, doing your due diligence is good. Then in terms of treatment, this is all in development, and no major recommendations yet, but a lot of different things have been tried and are being explored. I think the first thing is just treating other medical illnesses that could be contributing and other comorbid psychiatric conditions in the way that you normally would. There's nothing too special about treating them in the context of COVID, especially if they were present before. There's a big emphasis on more psychotherapy and behavioral strategies, because a lot of the symptoms have to do with fatigue, lack of energy, and motivation. So it's a really good opportunity for behavioral activation strategies. They've studied graded exercise therapy, which is basically just building tolerance over time for increased activity, and sort of pacing strategies. They've studied CBT, cognitive rehab, which is something that occupational therapy or speech can help with. And then emphasizing sobriety from substances, especially given how much more substance use there is in substance use disorders after the pandemic. And so that, of course, could be contributing to cognitive symptoms and is important to address as well. And then in terms of medications, eliminating other things that could be causing issues is the first step in kind of minimizing polypharmacy. You want to take steps to prevent progression of severe disease or them getting COVID again in the future. Likely something we will all get probably multiple times in our life. So emphasizing being up to date on vaccination, access to Paxlovid. And then there's nothing FDA approved right now for treatment of long COVID, but it's something that they're investing a lot of energy in studying. So all of these are off-label uses, and the treatment overall is very symptom-driven. And so it is very much based on what specific symptoms the patient has. So if they're more depressive symptoms or anxiety or PTSD, then using SSRIs. They've also studied vortioxetine and bupropion. They have looked into the kind of cognitive enhancer medications, given some of the cognitive deficits. These are both the donepezil and the mantine under investigation, but nothing yet really that supports their wide use. There are case reports on certain patients that have benefited, but nothing real like widespread yet. And then of course, because there's low energy and motivational issues, studied stimulants, and most case reports or small studies have been on modafinil, lisdexamfetamine, and methylphenidate. And in some cases, they are helpful in improving symptoms and something to consider kind of as a short-term management strategy if someone is really debilitated and unable to work or go about their day-to-day life. So something to consider in certain populations. And then kind of even more off-label treatments. They've been studying N-acetylcysteine, which it seems like they've been studying for everything lately, as well as naltrexone. I'm not quite sure on the mechanisms of these or what symptoms they're targeting, but I just in the kind of review of what's being studied, these have come up as current trials. So I think using medications and framing it as a way to treat symptoms is the best approach right now. And then also providing validation and reassurance that, yes, this is a very real thing, very debilitating. It's affecting a lot of people. The majority of the time, people do get better. It may take 3 months or 6 months or longer, but most people do end up being able to overcome these symptoms, and it just takes time and patience. And we'll know more as we're more years out from the pandemic, how long exactly the symptoms last or other strategies to help out. But I think framing it in that sort of context can at least provide people some hope and kind of give them some answers and just explanation about what's going on. Any questions about that, or like anything that people have tried on patients or experiences people have had seeing patients with symptoms after COVID?
Yeah, this is Will Brazil. I've used stimulants for some individuals as well as armodafinil, which we have on formulary as a leader, and yeah, different degrees of success for certain individuals. And some have been able to, interestingly, kind of get off, after a half year or a year or so. I don't know if it could just be further recovery.
Mm-hmm. Yeah. I think all of it is just, very kind of patient specific right now. And which is frustrating because it's hard to know like what exactly to do and how, the prognosis and what percent of people this might be a long-term thing, or maybe something that was treating something pre-existing, or like a tendency of just humans to want to attribute their symptoms to something and putting it on COVID because that's been on everyone's minds for years. So I think that is why it's so tricky to navigate, and hopefully as we progress in terms of research, we can have kind of more answers and solid recommendations.
Nick, I don't remember exactly, so forgive me, who was saying this, but I know that there was someone who used ketamine for their long COVID symptoms after trying, all different types of medications and stuff, and had success with that. So I was curious if you ran across anything in there about ketamine.
Yeah, I don't think I saw that when I was reviewing, but I'm sure people have tried it. I think people are just kind of trying a lot of different things, and there are likely case reports on like a bunch of different treatments, and it's just kind of a result of being kind of an evidence free zone right now, as people just are more using experimental treatments right now. But I think, it's a good idea, especially if there's a lot of depressive symptoms or even PTSD or substance use. Could be a cool treatment. Okay, so summary. SARS-CoV-2 as a virus appears to have neuroinvasive properties that we know have both structural and functional clinical impacts on the brain. In terms of acute COVID, there are associated unique features within delirium with acute COVID and a higher correlation with akinetic mutism, and then this potential increase in risk of psychosis. And then in terms of long COVID, it's a complicated syndrome, data supporting that there is a significant impact on cognitive symptoms. And right now the treatment is mostly symptom-based, kind of under investigation. And then as psychiatrists, we're in a unique position now to help patients at this stage of the pandemic. And I think in some ways it's kind of the newer front lines because, like I said, most people now have gotten COVID, and it's just going to be something that's with us forever now. And so a lot of reasons that people are having more disability after COVID is for the neuropsychiatric issues, and something that's in our wheelhouse to be able to help. So with that, any last questions or comments?
Sure, if that's okay. Yes, thanks so much, Dr. Tacke, for a really, really interesting presentation. And I was wondering, I had been reading a bit about kind of the, neuroinflammatory sequela, and, there's certainly ideas about depression in general being kind of neuroinflammatory in some respects. And so I was curious about, are there ideas about, modulating immune function as a way of treating this, so like neuroinflammatory modulators or things like that?
Yeah, that's interesting. Some of the long COVID clinics emphasize more treatments with things like steroids or antivirals, or more of just like targeting the virus itself, as opposed to like just kind of doing symptom management with psychiatric medications. And there have been promising results in that as well. So I think it seems like it supports that there is like an inflammatory or like kind of very neurobiologic impact of the virus, and just emphasizing the treatment through the source and getting rid of the virus, like does seem like it's an avenue. And so I think the reason why it's interesting is that it's very multidisciplinary. Like it has the kind of medical treatments that can help, psychiatric treatments, psychologic treatments. So everyone's kind of doing their part and trying to figure out the best path forward. But it seems like, yeah, treating just the virus does like help in general. All right.
I was also just going to chime in, kind of related to what you were speaking about, and what Dr. Browning was kind of touching on regarding ketamine. Not specific to long COVID, but it is pretty interesting to read about how ketamine is kind of its mechanism of action is thought to be rooted into the relationship between depression and being in a more inflammatory state. Since tryptophan, when it's kind of used in serotonin synthesis, it could be routed that way, but when someone's kind of in a more ill state, it gets routed into something I never really learned about until the past year, called the pynurenine pathway, which leads to kind of more inflammatory or production of kind of inflammatory molecules. And ketamine is kind of thought to inhibit that pathway from fully go down. So it's just kind of an interesting thing to read about. I'll post an article about it in the chat if you're interested.
Yeah.
Yeah, I guess another thought related to that. It's been interesting to see At the VA, we have a lot of individuals who seem to experience kind of have known to have mood disorders, depressive disorders, who are kind of known to clinicians here who show up with kind of worsening of suicidal ideation or depression, have been found to be COVID positive over the past few years. So it's definitely, it seems to be a clear link there between infection and worsening of mood disorder.
Yeah, and that was something that was emphasized too at the conference I went to. I went to a presentation similar to this, and they were saying how really anyone with a psychiatric disorder, it likely will get acutely worse when they're sick with COVID, just one, because they're feeling terrible, and then also potentially just the excess inflammation, all these other things, lack of access to support resources and all those things. And so being careful and like mindful of that, and kind of expecting that likely patients who are more kind of on the edge getting COVID could be something that's a risk factor, kind of important to look at. All right, well, we're out of time, but I appreciate everyone being here and listening and your questions. And everyone, takes care. And the slides and the recording will get sent out if people want to review them or look at their references and stuff and learn more. So appreciate you all and take care.